So when we look at pharyngitis or tonsillitis, it's literally defined as inflammation of the throat or the tonsils. It can be either viral in nature or bacterial. Usually, if you got a whole lot of snot, it's viral in nature. If there's not a whole lot of snot, and you have more pain in the throat or in the tonsils, it is usually bacterial. You can develop as complications some peritonsillar abscesses, you can develop rheumatic fever, and acute glomerulonephritis. So interestingly enough, that your kidneys and glomerular structures are going to be involved. That ends up happening usually because of the exposure to group A streptococci, which is the bacterium that causes a lot of pharyngitis or tonsillitis. Some of the signs and symptoms you're going to see are abrupt onset of throat pain. They're going to have fevers, difficulty swallowing, headache, abdominal pain, bruising or petechiae on their palate. They're going to have the exudates, which is the pus, and sometimes their tongue can be kind of swollen and red, which is like a strawberry appearance. We're going to do rapid streps and throat cultures, and we're going to attempt to do as many of the specimens where we're digging at the back of their poor little throat or their nose. We're going to do those specimens at the same time. So if we're doing the MRSA swab, and then we know that we're probably also going to have to swab the back of their throat to test for the rapid strep, and we're going to have to do a throat culture. We're going to try to do all of those at the same time so that we get the annoyance and the pain and the being scared out of the way. So some of the nursing management for pharyngitis and tonsillitis is saline gargles. I do want you guys, if you are giving education, to remind parents to never use sink or tap water to flush the nasal passages. So if they're going to do a saline flush on an infant or a small child through the nostrils, they need to use distilled water and add a saline packet into it. Anywho, we're going to do saline gargles, we're going to give them analgesics, we're going to give them little things to suck on to make their throat feel better. We should use a cool mist humidifier, although frankly, there's not a whole lot of evidence that it has to be cool mist, just needs to be humidified oxygen. And we're going to try to increase their PO fluids. If that means giving them a popsicle every hour around the clock, we're going to do it. If it's a viral pharyngitis or tonsillitis, we're going to do complete symptomatic relief with the interventions I just listed. If it's bacterial, they're likely going to receive penicillin for 10 days. So when we're educating the parents, we want to make sure that they know if it is viral, we are not going to give them antibiotics. It's not going to do any good. And we're going to explain to them and educate them why giving them antibiotics for a viral illness, although it might make them feel better, will not improve the health of their child in the end. It's actually going to not benefit them at all and be detrimental, creating bacterial resistance. If they do have a bacterial pharyngitis or tonsillitis, we're going to remind them they have to complete all the medications. We're going to give them literally printed out instructions on how to make a saline gargle and how to have the child do it. They're going to take 8 ounces of warm water. They're going to mix a half a teaspoon of salt into it. They're going to have the kid put it in their mouth if they're old enough to follow these instructions, gargle with it, and then spit it out. After 24 hours of receiving antibiotics, the kid can go back to school. We want to educate the parents to get rid of things that they might use on a regular basis that go in their mouth, such as the new toothbrush. That's going to carry all those gross bacterial strains that caused this illness in the first place. So get rid of the toothbrush. If they're sharing a little toothbrush holder with other children in the household, maybe everybody needs a new toothbrush because we don't need them cohabitating those bacteria on each other's toothbrush just from being too close. If it's a child that's 5 years old or 4 years old and still sucks on a pacifier, probably need a new one. Not a good idea. We're just putting the same old grossness back in their mouth. We're going to tell them to really clean those sippy cups, boil them, bottles as well. Okay, Okay, if a child has had a tonsillectomy, one of the best things you can know is that bleeding in the back of the throat after the tonsillectomy is most often identified by continuous or repetitive swallowing. If the parent says they see the kid swallowing all the time and they're 6 hours to a day past tonsillectomy, they might be bleeding too much and they're swallowing it. So we want to promote airway clearance. We want to put the child in a side lying or a prone position. We don't want to let them lay on their back. It's not a good place to be pooling up blood and different liquids in the back of their throat. We want to maintain their fluid volume, but we also need to avoid citrus because it's going to burn and hurt. We also need to avoid brown or red fluids, so don't give them red Gatorade, don't give them soda, because when you vomit up blood, sometimes it's brown. Sometimes when you vomit up blood, it looks like red Gatorade. So we don't want to have to wonder which one it is. We want to discourage the child from coughing, constantly clearing their throat, from blowing their nose, and we also don't want them using straws. It's not because the act of sucking is an issue, it's because we don't want them to injure themselves with it. We're going to give them as much pain relief as we can. Some doctors order narcotics, some don't. Allergic rhinitis. It is intermittent or persistent inflammation. So this is an allergy that causes swelling. I'm not going to get into histamine and leukotrienes and all of that stuff, late phase mediators, basophils and mast cells. I'm just going to tell you, they get a lot of vasodilation in the nasal areas. They get watery nose running. We've all been there. This is Bakersfield. They get itching, sneezing, red eyes. Sometimes if they have had other respiratory issues like asthma, having allergic rhinitis can complicate their asthmatic symptoms. They're going to frequently develop recurrent sinusitis. They can also develop recurrent ear infections, otherwise known as otitis media, and it can also cause some dental issues. Kids can have allergy testing on the skin. Ugh, anybody who's ever had allergy testing knows it is not great. We're going to manage these people with nasal washes. Again, never using sink water, only distilled. Going to get an amoeba smushed up your nose to your brain. Don't do it. They can use corticosteroid nasal sprays, mast cell stabilizing nasal sprays, oral antihistamines. A lot of the time, these kids need to be on allergy pills all their lives. Every single day. Should not be a seasonal thing. We're going to tell the parents how to avoid the allergens. Common allergens are smoke, dust mites, pet dander, cockroaches. Did you know that? Indoor molds, outdoor mold, pollen, Bakersfield. Bakersfield has so much pollen and air pollution. It is amazing. So we're going to teach them. Croup. Croup is related to inflammation and edema in the larynx, trachea, and bronchi. It's usually a viral infection. It's usually caused by a virus called parainfluenza, and it usually happens in a child 3 months to 3 years old. So, the subglottic area of the trachea, if you can imagine, right behind and under where your tongue sits in the back of your throat. That is now narrowed, swollen, inflamed, and filled with mucus. These children will develop audible inspiratory stridor. I need you to look up that sound, listen to it. They're also going to develop edema of the larynx, and that causes a barking cough. Sometimes people say it sounds like a duck. Some people say it sounds like a seal. I have included on the respiratory board, if you look at it, and watch some of those videos, some really great examples of the croup cough. Some of the complications from croup, which they are rare, but it can happen: respiratory distress, hypoxia, and then bacterial superinfections. Superinfections with bacteria are common in any area in our body that gets too swollen and too mucousy. We're just kind of creating a petri dish for something to grow in. So bacterial superinfections can occur, and they can be very hard to treat. Some of the signs and symptoms of just regular old croup: it's often happening at night. It comes on suddenly. The kid is perfectly fine during the day. They lay down to go to sleep, and then the barking, cough, and the stridor starts. It lasts about 3 to 5 days, and they have mild upper respiratory infection symptoms like runny nose. So some of the things we're going to do to treat croup, they're done usually as an outpatient. If the kid has really bad stridor at rest, severe retractions, they might be admitted to the hospital. They're going to get corticosteroids. They can have racemic epinephrine, which is an inhaled form of epinephrine. They can have that to help dilate the bronchial tubes. This usually wears off after about 2 hours, so it's not great. You have to really pump them full of epinephrine to get this to work. Anecdotally, which means we hear a lot and see a lot that it works, but there is no proof in a sustained study. So anecdotally, cool mist humidifiers or a steamy bathroom are great, and you're going to hear every grandma or mom tell you a story about when you or your mom or your aunt or uncle had really bad croup, and they put them in the car and rolled the windows down to try to help them breathe, and they were taking them to the hospital, and by the time they got to the hospital, the kid was fine. And this is usually because the air is more humidified at night. They're getting good airflow in their face from the windows being down, and they're calm. So anecdotally, cool mist and steamy bathrooms work. We're going to educate parents to use the humidifier, or just make a really steamy shower and sit in there with your kid. Some parents, I tell them, if you have to take a shower and you like a really steamy hot shower, put that baby in the car seat, sitting right outside the shower door. I will also, if you remind me, guys, teach you how to put a roll behind the shoulders of the babies that are in car seats so that we can extend their little necks a little bit, which improves their aeration. Epiglottitis. This is inflammation and swelling of the epiglottis. So, usually caused by Haemophilus influenza type B, HIB. It is rare now because they do get vaccines for this between 2 and 7 years old. unfortunately, we can still see it, what with the advent of lots and lots of vaccine hesitant parents. We can see some complications from epiglottitis that are respiratory arrest and death. It is, in its severest form, a medical emergency. These children are going to come in and they're going to be having dysphagia, so they're unable to eat. They're going to be having a lot of drooling, a ton of anxiety. The reason they're drooling is because they can't even swallow their own spit. They're super anxious, irritable, and they're having significant respiratory distress. They look like poo. They're sitting forward, kind of like a tripod that you would see in an elderly person with COPD, just really trying to get those breaths in. They're going to have their neck extended because they are trying, even though they don't realize it. You'll see this in toddlers. They're trying so hard to stretch their little necks out to get any airflow through there. So we're usually going to do an x-ray of the neck to confirm. If they're having extreme symptoms, we're not going to waste time doing this. We need to have, as you can see in our cute little slide here, we need to have emergency equipment ready at the bedside. We need to provide the child with airway management, antibiotic therapy. We're not going to leave them alone. We are not going to try to look at their throat because we could injure it more and make the swelling more. And then for sure, it's very much an emergency. It's a code, well, it's a rapid response at least. We're not going to put them in a supine position. We're going to keep them sitting up as high as we possibly can. We're going to give them 100% oxygen in the least invasive manner at pretty high flows, and we are going to be prepared to do a tracheostomy if they develop complete airway obstruction. Most of the kids with epiglottitis are going to go straight to the PICU.